Hello students, today I'll give my last lecture, which is about surgery for congenital heart disease. Regarding the etiologic basis for congenital heart disease, primary genetic factor account for about 10%, but the majority there is a genetic environmental interaction which account for about 90% of the situation. Environmental contribution to genetic factor, for example, drugs, infection, maternal condition, for example, diabetes, and old age, which have greater susceptibility for the embryo to develop genetic mutations, for example. Potential cardiovascular teratogens like drugs, for example, alcohol, anticonvulsants, infections like rubella, Coxsackie virus, maternal condition, for example, old age, diabetes, lupus erythematosus, and so on. Maternal risk factors like advanced age. You know that with the progress of the maternal age, there is a higher chance for incidence of congenital heart disease and genetic mutation, for example, baby getting Down syndrome. Maternal congenital heart disease may be transferred to the children. Diabetes mellitus, systemic lupus erythematosus, and so on. Trisomy 21 may lead to may be associated with various congenital heart disease, for example, VSD, transposition of the great arteries, cardiomyopathy, heart block, tetralogy of Fallot, VSD coarctation, hyperplastic left heart syndrome, and so on. Incidence and classification of congenital heart disease. You probably heard that in the majority of the cases, or roughly, congenital heart disease can be divided into cyanotic, acyanotic, or non-cyanotic congenital heart disease. But the most recent and the most reasonable way for classifying congenital heart disease is in this way. We can divide into lesions that lead to left to right shunt. And by the way, whenever there is left side to right shunt, this is usually those babies are pink babies until later on in advanced stage, which may get, for example, Eisenmenger syndrome, and the situation may reverse. Left is contain oxygenated blood. When there is left to right shunt, so they are pink babies. For example, PDA, ASD, VSD, atrioventricular septal defect, and abnormal pulmonary venous return. While the second class, which is right to left shunt, whenever there is shunt from the right side toward the left side, so you know that the right side contains deoxygenated blood, and when this deoxygenated blood shunted to the left side, it will mix with the oxygenated blood, and this will lead to some decrease in saturation and cyanosis, and this may be apparent according to the degrees of the shunt and severity of the disease. Tetralogy of Fallot, for example, tricuspid atresia, pulmonary atresia with VSD, pulmonary atresia with the ventricular septum. Third class of congenital heart disease, for example, admixture lesions like transposition great arteries, univentricular heart, atrial isomerism, double outlet right ventricle, truncus arteriosus, corrected TGA. Obstructive lesion, in some conditions we have just obstruction, for example, either to the right side or to the left side of the heart. Left side obstruction, for example, coarctation of the aorta. I mean, in the pathway afterload of the left side, there is some obstruction or some stenosis, for example, like coarctation. While on the right side, for example, pulmonary stenosis. Pulmonary stenosis may be supravalvular above the valve in the pulmonary arteries are small or stenotic, or subvalvular in the infundibulum. Mitral stenosis, left ventricular outflow tract obstruction, hypoplastic left heart syndrome, and so on. Valvular lesions like Eberstein anomaly, which involve the tricuspid valve, aortic regurgitation, mitral regurgitation, and sinus of valvular aneurysm. Evaluation of congenital heart disease by history taking in infants, symptoms of congestive heart failure, poor feeding, low weight gain, tachycardia, tachypnea, sweating, and anxiety, and frequent upper respiratory tract infection. These are features that the baby may have some sort of congenital heart disease. Symptoms of hypoxemia, cyanosis, hypoxic spell may occur, especially hypoxic spell in severe type of tetralogy of Fallot. Children, there may be murmur, symptoms of congestive heart failure, exercise intolerance. You see that those children with congenital heart disease, they have a lower tolerance and tolerability for exercise as their age mates. Surgical indications and optimal timing of operation. We divide surgery for congenital heart disease into either it's a palliative type of surgery or it's a corrective type or definitive type of surgery. Palliative surgeries, we have systemic pulmonary artery shunt, right ventricular outflow tract obstruction, pulmonary artery banding, and atrial septectomy. These are some form of palliative surgery. What we mean by palliative surgery? Sometimes corrective surgery is not possible due to age or size of the patient or due to other medical conditions of the baby. So in this situation, we do some sort of palliation. We prepare the baby for the next stage, which is the corrective surgery. Because these palliative surgeries have low mortality, low morbidity, and they are easy to perform, and they don't need special capacity and capability for doing them. Systemic pulmonary artery shunt, we have Blalock-Taussig shunt, cavopulmonary shunt. What's Blalock-Taussig shunt? Blalock-Taussig shunt is, and this is by the name of the cardiologist and the surgeon. Blalock is the surgeon, Taussig is the pediatric cardiologist. She was pediatric cardiologist. We make a connection between, or we create a shunt between the aorta and the pulmonary artery. Cavopulmonary shunt, we connect the superior or inferior vena cava with the pulmonary artery. Later on, I'll discuss how we do that and what's the benefit. Right ventricular outflow tract obstruction and reconstruction. For example, if it's due to the valve, you may do valvotomy. If it's infundibular or supravalvular, or stenotic pulmonary artery, we may do patch widening, or we may connect a valve conduit that's directly, we make an opening in the right ventricular wall, and we connect the distal part with the branch pulmonary arteries. Systemic pulmonary artery shunt. Systemic, we mean arterial system. Pulmonary artery shunt is indicated due to age, for example, premature baby, size, low birth weight. Anatomy, if the situation or the congenital is so complex or so difficult that corrective surgery in that stage is not possible. A complex anomaly with severe cyanosis and irritability, these are indications for doing systemic pulmonary artery shunt. Critically ill neonates or infants do decrease pulmonary flow, facilitating growth of a hypoplastic pulmonary artery. In those critical neonates or infants due to decreased pulmonary flow, this systemic pulmonary artery shunt is done for cyanotic lesions. Generally, it's done for cyanotic congenital heart disease. How cyanosis in congenital heart disease occurs? Because usually it's due to reduced blood flow to the pulmonary circulation and reduction in the level of oxygenation of the blood, which lead to hypoxemia. So what the principles of this surgery is to increase the pulmonary blood flow. By doing what? By creating a shunt between the aorta and the pulmonary artery. And you know the aorta is high pressure and the pulmonary artery is low pressure. So the shunt is usually from left to right. We will increase the blood flow to the pulmonary circulation, and by this way we increase the ratio of oxygenated blood, and so the cyanosis will disappear. In some situation, we have rudimentary pulmonary arteries and pulmonary artery branch. In this situation, when you connect this we transfer the systemic pressure from the aorta to the pulmonary artery through the shunt, it will enhance growth of pulmonary branch, and the baby may become ready for the next total repair surgery. Pulmonary artery banding, this is in contrary to the pulmonary BT shunt or Blalock-Taussig shunt or systemic pulmonary artery shunt. This is in contrary. What we do, we reduce the blood flow to the pulmonary arteries. Why? Because in those congenital heart diseases, especially left to right shunt, for example, multiple VSD, there will be higher blood flow to the pulmonary arteries. This high blood flow to the pulmonary artery, the pulmonary arteries will protect itself by vasoconstriction, and this vasoconstriction with time become fixed and irreversible. And this irreversibility of pulmonary vasoconstriction, when it's irreversible, this means pulmonary artery hypertension, and pulmonary artery hypertension, whenever it's irreversible, fixed. So we go into the stage of Eisenmenger syndrome, and those patients are not for surgery, definitely. So we protect the pulmonary artery bed by what? By creating a stenosis in the pulmonary artery, by reduction of the flow of blood to the pulmonary circulation. Control of congestive heart failure, definitely when there is higher, it may lead to right-sided heart failure, complex multiple VSD plus coarctation, and when cardiopulmonary bypass medically contraindicated and we cannot do final repair for the lesion. In these cases, we do some sort of PA banding. PA banding can be done through a small thoracotomy, anterior thoracotomy in the second intercostal space, and from this small incision we go around the pulmonary artery, and we take a tape and gradually constrict this tape until some special measures occur that we need during operation, and by this we clip the band, and this is we clip the band, and this is the degree of stenosis which we need. Atrial septectomy in some congenital lesions. For example, in transposition of the great arteries, if there are not any connection between the left and the right side of the heart, so the circulations are parallel. There is no any way of admixture between the left and the right side, and you know that the systemic blood is from the get blood from the right atrium, which is deoxygenated blood, and the the aorta arises from the right ventricle, which receives deoxygenated blood, and the pulmonary artery arises from the left ventricle, which receive apparently oxygenated blood. So in this situation, we have to do some sort of admixture between the two systems so that some oxygenation can occur between these systems, right and left side. Indication for arterial septectomy, for example, TGA, tricuspid atresia, pulmonary atresia, and there is a decreased tendency for indication due to ill total correction in this group, or sometimes nowadays actually they are doing arterial septectomy through cardiac catheter. Reparative surgery, corrective surgery. Corrective surgery, some surgeries can be done through open heart surgery, others through non-open heart surgery. Some, for example, like PDA or coarctation, they are done through a small thoracotomy, and others, intracardiac repair through open heart surgery can be done. In some cases, palliative procedure that we did previously may be the reparative procedure, and we cannot go beyond that. So, reparative surgery sometimes palliative procedures may be the reparative procedure also. For example, univentricular heart. You have single ventricles, and you have a single ventricle, so you do some sort of palliation in this single ventricle. So you cannot go beyond that. You cannot create another ventricle to do complete total correction. And regarding the palliative procedure, we may do, regarding the reparative procedure, we may do anatomic correction, complete anatomy, and we make it as a normal anatomy, or we may do physiology. In some situation, the anatomic correction is not possible. So what we do physiology correction. For example, in transposition of the great arteries. As we said, the aorta arises from the right ventricle, pulmonary artery arises from the left ventricle, and the right ventricle is filled by the right atrium, which contains deoxygenated blood. We direct the deoxygenated blood from the right atrium. We redirect this deoxygen to the left ventricle, so that pulmonary artery arises from the left ventricle, and this blood will go to the pulmonary arteries, and they will be oxygenated back. And we direct the left atrium toward the right ventricle to be pumped by the right ventricle and distributed through by the aorta. This is called a physiologic correction. So, corrective procedure, non-open heart surgery like PDA, coarctation of the aorta. Patent ductus arteriosus. There is an open communication usually between the upper descending aorta and proximal portion of the left pulmonary artery. Significant PDA indicated after first month of life of the neonate or the infant. Prophylactic closure, if it's not significant, so there is no features of heart failure, feature of pulmonary hypertension, we may do prophylactic closure within 6 to 12 months of age. Symptoms of heart failure or failure to thrive usually indicated at any time. Severe pulmonary vascular disease, pulmonary hypertension, this is development of Eisenmenger, this is a contraindication for surgery. Coarctation of aorta. There is a congenital narrowing of upper thoracic aorta adjacent to the ductus arteriosus. Operation is indicated when reduction of luminal diameter more than 50%, Upper body hypertension more than 150 millimeter mercury in young infant with congestive heart failure at any age. Coarctation with VSD. Why coarctation with VSD? Because coarctation causes afterload, increase in afterload of the left ventricle and some obstruction. So this will increase the shunt through the VSD, and those VSD, even if they are small one, they have a greater chance that may lead to pulmonary vascular disease and pulmonary hypertension. This is the narrow aorta. ASD, atrial septal defect with partial anomalous pulmonary venous return. Sometimes the ASD may be alone, a defect in the interatrial septum. It may be alone by itself, or may be associated with partial anomalous pulmonary venous return. What's partial anomalous pulmonary venous return? And this is a situation in which some of the pulmonary veins, one or two of the pulmonary veins, instead of being drained into the left atrium, they will drain into the right atrium. So during repair, we close the ASD and we redirect these pulmonary veins into the left atrium as its normal anatomy. The location of ASD may be in the fossa ovalis, maybe posterior rim or ostium primum, maybe coronary sinus or sinus venosus type of ASD. Uncomplicated ASD or PAPVC with the RV volume overload. What we mean by QPQS, the ratio between the pulmonary blood flow. If you divide, for example, if the pulmonary blood flow is 5 liters and the systemic flow is 3 liters, so this means that the pulmonary is higher, pulmonary flow is higher. These measures can be done through cardiac catheterization. So if this ratio between pulmonary flow and the systemic or arterial flow is more than 1.5 or 2, is an indication for surgery. Optimal age usually preschool, but recently 1 to 2 years of age to reduce or to eliminate the chance of RV volume overload. These are the ASD types. Ventricular septal defect, one of the most common congenital heart disease. There is a hole or multiple holes between the left and right ventricle. Symptomatic large VSD is an indication for surgery. Before 3 months, indicated in large VSDs with congestive heart failure or respiratory symptoms. But moderate or small sized, this is the story is something else. Moderate sized VSDs, QP, pulmonary flow ratio to the systemic flow, if less than 3 with few symptoms, this may need observation only during infancy, and later on during childhood you may do some corrective surgery. While small VSD, there is no any indication for surgery in these cases, but they are liable for infective endocarditis. Subarterial type of ventricular septal defect, that is, the VSD is adjacent to the large arteries, pulmonary or aortic artery. These are indicated for surgery, whatever the size it is. They are indicated for corrective surgery and closure whenever it's possible, and usually as soon as possible. Atrioventricular septal defect. Abnormalities of atrioventricular valve form and function and interatrial or interventricular communication from maldevelopment of the endocardial cushions. In this situation, what we have, there is the patient has, the baby has ventricular septal defect, atrial septal defect, septum primum type atrial septal defect with abnormality of the AV valve. Presence of atrioventricular septal defect is indicated is indicated with the presence when it is diagnosed as indication for surgery. We have three types. We have partial, complete, and transient type of atrioventicular septal defect. Partial atrioventicular septal defect. In this situation, what we have ASD primum with cleft in the mitral and tricuspid valve, maybe, but there is no VSD. In this 1-2 years of age, surgery is indicated whenever there is congestive heart failure or growth failure. Otherwise, you can postpone the surgery. While complete atrioventicular septal defect, 3 to 6 months of age is the proper timing for intervention and surgery. Of course, if refractory heart failure, respiratory symptoms at any age, you have to do something about that. Development of pulmonary vascular obstructive disease is a contraindication for Eberstein anomaly is a congenital defect of tricuspid valve in which the origin of the septal and posterior leaflets of both are displaced downward into the right ventricle, and the leaflets are variably deformed. There is arterialization in this situation, congenital heart disease. There is arterialization of a part of the right ventricle, so that the tricuspid valve will be displaced downward. This congenital anomaly may be associated with cyanosis, palpitation, WPW syndrome. If there is TR, we have to do repair. We have to do, usually associated with ASD. We have to do repair for the ASD, and we have to do repair for the tricuspid regurgitation if present. WPW syndrome is, if present, we have to do ablation surgery. Ablation therapy, sorry. Pulmonary stenosis, a form of RV outflow, right ventricular outflow obstruction, in which stenosis is usually valvular or both valvular, infundibular, or only infundibular. What we mean by infundibulum? In the right ventricle, right ventricular cavity will narrow before reaching the pulmonary valve. This tubular narrowing between the pulmonary valve and the proper right ventricular cavity is called infundibulum. Sometimes this infundibulum contains hypertrophied trabeculated muscle, which lead to stenosis of the right ventricular outflow tract, and a form of pulmonary stenosis. Critical pulmonary stenosis is indicated in neonates immediately if the diagnosis is made, and usually through instrumentation and catheterization by balloon valvotomy. Valvotomy with cardiopulmonary bypass may be an option also whenever it's not possible through catheterization. Transannular RVOT patch widening. Infants, BS in infants and children indicated with symptoms and pressure gradient more than 50%. What we mean by pressure gradient means pre and post valve pressure. We measure it through catheterization. If the gradient, the difference between pressure post-pre valve more than 15 millimeter mercury, this is an indication for intervention. Of course, surgical intervention is not indicated with mild stenosis. Tetralogy of Fallot. This is the most common congenital cyanotic congenital heart disease, and characterized by the following. We have VSD, right ventricular outflow tract obstruction, in the form of pulmonary stenosis. We have right ventricular hypertrophy and overrided aorta. If the overrided aorta is not there, This means that it's only VSD-PS, no more than that. It's not a tetralogy. Sometimes if it's associated with ASD, it's called pentalogy. Diagnosis by itself is an indication for operation. If age, complexity, and sepsis does not allow for total correction, so we may put a shunt. And later on, we may do total corrective repair. Usually, total correction at the age of 3 to 24 months, and multiple VSD LAD from the left anterior descending coronary artery, because tetralogy of Fallot may be associated with abnormality of the coronary arteries. In this situation, for example, LAD, left anterior descending coronary artery, may cross the right ventricular outflow tract, and this you cannot do right ventricular outflow repair. In this situation, you will be obliged to do some sort of palliative surgery until later age. Transposition of the great artery, second most common or cause for cyanotic congenital heart disease. In this situation, in this condition, there will be parallel circulation. Right aorta arises from the right ventricle, and the pulmonary artery arises from the left ventricle. What we do in this condition, usually it's fetal diagnosis, and immediately after intrauterine diagnosis and echocardiography should be done, and those patients are usually prepared for surgery and within the first month of neonatal life, because after that there will be no benefit from total correction of the situation. Arterial switch. In this arterial switch operation, what we do, we switch the pulmonary artery. We make the pulmonary artery, transfer the pulmonary artery into the right ventricle, and we transfer the aorta to the left ventricle. This is arterial switch operation. But if the age or the diagnosis delayed and the age gone beyond 30 days, so we cannot do arterial switch operation, which is anatomical corrective surgery. Why? Because this is the period that the muscles of the left ventricle should hypertrophy. After that, the left ventricle will lose the ability for hypertrophy and getting the systemic ventricle. If after 30 days, what we do atrial switch operation, physiological. We make the left atrium go to the right ventricle. We direct the blood from the left atrium to go to the right ventricle to be pumped via the aorta, and we direct the right atrium toward the left ventricle to be pumped by the pulmonary arteries to the pulmonary circulation. Tricuspid ischemia is another cause for cyanotic congenital heart disease. Usually, the tricuspid valve is rudimentary, as well as the right ventricle is rudimentary. So this is a univentricular heart. In this case, pulmonary vascular resistance is an important indicator for what we do in this situation. If pulmonary vascular resistance is more than 4 units, this is special unit measured during cardiac catheterization, actually. Woods unit, it's called Woods unit. If it's more than 4 units, It's a contraindication to do any sort of surgery in these cases, and they are for cardiopulmonary transplantation, heart-lung transplantation. 2 to 4 units we may do bicaval pulmonary, bidirectional cavo-pulmonary shunt. What we do by bidirectional cavo-pulmonary shunt, BCPS, in this situation we connect the pulmonary artery, is the superior vena cava, one of the vena cava, either superior or inferior, to the pulmonary artery. Or we may connect both of them, the inferior and the superior vena cava, blood directed into the pulmonary artery to be oxygenated, and we bypass the right side of the heart. This is called cavo-pulmonary shunt or Gillian shunt. Symptomatic in early life, if the tricuspid atresia, they are symptomatic at the very early life, so we have to do some sort of shunt or PA banding. Hypoplastic left heart syndrome, a wide spectrum of cardiac phenomena with various degrees of hypoplasia of the structures of the left side of the heart, including the aorta, the mitral, and the left ventricle itself. Diagnosis is an indication for operation. This is a hypoplastic. This is may cause cyanosis early in neonatal life, and diagnosis is an indication for operation when it is diagnosed, and the multi-stage procedure called Norwood operation, and the other definitive surgery for this situation is by doing cardiac transplantation. Cardiac transplantation for congenital heart disease, you know that cardiac diseases that has a poor prognosis for short-term survival, less than 1 year, and that's not treatable by conventional therapy, these are candidates for cardiac transplantation. Contraindication includes severe and life-limiting coexisting medical problems, active bacterial viral infection, psychosocial family situation, and presence of severely elevated pulmonary vascular resistance more than 8 Wood units. So in this case, those patients, they need both lung and heart transplantation. Thank you.